Hi, I'm Dr. Maria Corcorran, and in this Hepatitis B online mini lecture, I will be discussing management of Hepatitis B and HIV coinfection. Globally, an estimated 7 to 10% of people with HIV have chronic hepatitis B infection, most of whom acquired hepatitis B through perinatal transmission. In the United States, the prevalence of chronic hepatitis B is estimated to be 0.3 to 0.7% in the general population. However, 5 to 15% of people with HIV in the US are estimated to have chronic hepatitis B. In the United States, the most common risk factors for hepatitis B acquisition are sex and injection drug use. Persons with HIV who are exposed to hepatitis B are more likely than those without HIV to develop a chronic hepatitis B infection. And HIV and hepatitis B coinfection can lead to accelerated progression of liver disease, including increased risk for hepatocellular carcinoma, liver-related mortality, and all-cause mortality. Even in the modern antiretroviral era, hepatitis B remains a major contributor to end-stage liver disease and liver-related deaths among people with HIV. Vaccination remains the key pillar of prevention for hepatitis B. However, vaccine uptake remains suboptimal. The HIV Opportunistic Infections Guidelines recommend vaccination in all HIV-positive individuals without chronic hepatitis B, without immunity to hepatitis B, or without past exposure to hepatitis B, as evidenced by a negative hepatitis B surface antigen, negative surface antibody, and negative core antibody. Unique to people with HIV, the Opportunistic Infections Guidelines also recommends vaccinating individuals who have a positive hepatitis B core antibody, but a negative surface antigen and negative surface antibody. This is also referred to as an isolated core antibody and indicates prior exposure to hepatitis B with either inability to mount a surface antibody response or, more commonly, a waning surface antibody titer. The preferred option for vaccination in persons with HIV is Heplisav-B, which is a 2-dose single-antigen hepatitis B recombinant vaccine dosed at months 0 and 1. Alternative options for vaccination include a double dose of the single-antigen vaccines Engerix-B or Recombavax HB, both doses given at months 0, 1, and 6. Alternatively, a standard dose of the combined hepatitis A and hepatitis B vaccine Twinrix can be given at months 0, 1, and 6. As mentioned in the prior slide, Heplisav-B is the preferred vaccination for people with HIV. This single-antigen hepatitis B recombinant vaccine consists of recombinant hepatitis B surface antigen combined with the synthetic immunostimulatory cytidine phosphate guanosine oligodeoxynucleotide 1018 adjuvant. The CpG adjuvant binds to toll-like receptor 9, signaling an innate immune system pathway in response to the hepatitis B surface antigen. Data for this vaccine in people with HIV comes from the BEe-HIVe study, which was an open-label trial of 3 doses of Heplisav-B given at 0, 4, and 24 weeks in hepatitis B vaccine-naive people with HIV. 74 people with HIV were enrolled in this study, 46% were males, the median age was 47 years, median CD4 count was 625, and nearly all were virally suppressed. 4 weeks after the 3rd dose, 100% of study participants had a hepatitis B surface antibody level that was greater than 10. However, notably at week 24, prior to the administration of the 3rd dose, 98.5% of individuals had an antibody level that was greater than or equal to 10, suggesting a robust seroprotective response to 2 doses of Heplisav-B. Looking at other strategies for hepatitis B vaccination in people with HIV, a systematic review of standard dose versus double dose recombinant vaccines, including both Engerix or Recombavax HB, found a higher odds of serologic response defined as an anti-HBs level greater than 10 among those who received a double dose versus standard dose. This was true at both 4 to 6 weeks following vaccine completion and at greater than 12 months post-vaccine completion. However, it should be noted that response rates to a double dose of hepatitis B vaccine were still variable across studies, ranging from 47 to 88%. Persons with HIV who do not respond to an initial hepatitis B vaccine series should be revaccinated. If the vaccine non-response occurs after receipt of either the Endurex-B or Recombavax HB series, then a 2-dose Heplisav-B series should be administered at 0 and 4 weeks, with consideration of a 3rd dose of Heplisav-B at 24 weeks. If the vaccine non-response occurs after receipt of the 2-dose Heplisav-B series, there are no data on how to proceed, but clinicians can consider a 3rd dose of Heplisav-B given at least 24 weeks after the 1st dose. Data for the use of Heplisav-B in vaccine non-responders comes from a second arm of the BEe-HIVe study. In this arm, investigators enrolled 561 people with HIV with prior non-response to hepatitis B vaccination, and they randomized them in a 1-to-1-to-1 fashion to receive either 2 doses of Heplisav-B at 0 and 4 weeks, or 3 doses of Heplisav-B at 0, 4, and 24 weeks, or finally 3 doses of Endurex-B at 0, 4, and 24 weeks. The median age of study participants was 46, 36% were female, and 40 to 45% across arms were Black. The median CD4 count was in the 600s, and 94% had an HIV viral load less than 40 copies. Seroprotection was achieved faster among those receiving Heplisav-B, and a higher proportion of people receiving Heplisav-B achieved seroprotection. The rate of seroprotection in the 2-dose Heplisav-B group was 93% versus 99% in the 3-dose Heplisav-B group and 80% in the 3-dose Endurex group. Higher anti-HBs titers were also seen among those receiving Heplisav-B, with 96% of those in the 3-dose Heplisav-B group, 70% of those in the 2-dose Heplisav-B group, and 63% of those in the Endurex group achieving an anti-HBs titer of 100 or greater. As mentioned previously, one unique recommendation for hepatitis B vaccination among people with HIV is the recommendation to vaccinate persons with an isolated positive hepatitis B core antibody. In these settings, the HIV Opportunistic Infections Guidelines recommend giving 1 standard dose of hepatitis B vaccine, then checking a hepatitis B surface antibody 1 to 2 months later. If the surface antibody titer is greater than 100, the individual can be considered immune to hepatitis B. However, if the surface antibody titer is less than 100, the individual should complete the full hepatitis B vaccine series with another surface antibody titer checked in 1 to 2 months. With regards to hepatitis B prophylaxis, there are no randomized controlled trials of tenofovir for hepatitis B pre-exposure prophylaxis like there are for HIV. However, observational data among men who have sex with men on tenofovir for HIV treatment or HIV PrEP suggests there is likely a protective effect. Similarly, the provision of antiviral therapy in pregnant women with hepatitis B viral loads greater than 200,000 has been shown to reduce the risk of hepatitis B perinatal transmission by 13%. With regards to observational data supporting the use of hepatitis B active antiviral therapy as chemoprophylaxis, an observational study using data from the multicenter AIDS cohort study evaluated hepatitis B incidence in 2,375 hepatitis B negative MSM with and without HIV. In this cohort, 31% had received at least 1 dose of the hepatitis B vaccine at baseline. Over 25,000 person-years of follow-up, hepatitis B incidence was higher in MSM with HIV when compared to those without HIV, with an incident rate ratio of 1.9. Among individuals with HIV, the incidence rate of hepatitis B was significantly lower among those on antiretroviral therapy with a viral load less than 400 when compared to those not on antiretroviral therapy with an incident rate ratio of 0.1. However, there was no significant difference in incidence of hepatitis B among those on antiretroviral therapy with a viral load greater than 400, which would suggest non-adherence, versus those not on antiretroviral therapy. Similarly, among 1,716 patients in the Swiss HIV cohort study who were hepatitis B negative at baseline, there were 177 incident hepatitis B infections. Incident infections were lower for persons on Hepatitis B Active ART. As shown in the table, hazard ratios for incident hepatitis B were lowest for those on tenofovir plus lamivudine and tenofovir plus emtricitabine, followed by those on tenofovir and those on lamivudine, further suggesting a protective effect of hepatitis B active antiretroviral therapy. Major guideline committees recommend initiation of hepatitis B active antiviral therapy in all HIV and hepatitis B co-infected persons, regardless of CD4 count or hepatitis B viral factors. The goals of antiviral therapy in this setting of co-infection are to 1. Reduce necroinflammation and hepatitis B DNA replication, and 2. Avert or delay development of cirrhosis, end-stage liver disease, and hepatocellular carcinoma. The table here outlines recommendations from major guideline committees in the US, Europe, and Asia, which all align on treating hepatitis B in co-infected patients regardless of CD4 count. They also all recommend using a tenofovir-based regimen, with most guidelines, including the US guidelines, recommending that tenofovir be co-formulated with emtricitabine or lamivudine. Collectively, there are 6 oral antiviral agents and 2 formulations of interferon alpha that have been approved for hepatitis B. However, only tenofovir disoproxil fumarate, tenofovir alafenamide, and entecavir are considered first line. Lamivudine monotherapy was previously used but is no longer recommended due to a 5-year cumulative resistance rate of 70%. Additionally, although entecavir is one of the first-line antiviral therapies for persons with hepatitis B monoinfection, entecavir has partial activity against HIV and can produce an M184V if not given with fully suppressive antiviral therapy, so it is less commonly used in cases of HIV co-infection. Among the 6 medications listed here with hepatitis B activity, only entecavir and tenofovir, which includes both tenofovir disoproxil fumarate and tenofovir alafenamide, have both high potency against hepatitis B and a high barrier to hepatitis B resistance. However, as mentioned previously, entecavir only has partial activity against HIV and therefore should only be used with a fully suppressive HIV regimen in the setting of co-infection. The choice of tenofovir alafenamide or TAF versus tenofovir disoproxil fumarate or TDF in patients with HIV and hepatitis B co-infection will largely depend on patient factors, including comorbidities. However, hepatitis B virologic outcomes were evaluated in a recent phase 3 double-blind randomized controlled trial that compared co-formulated bictegravir tenofovir alafenamide emtricitabine, also known as Biktarvy, to co-formulated tenofovir disoproxil fumarate emtricitabine, also known as Truvada, plus dolutegravir in persons with HIV and hepatitis B co-infection at 46 outpatient centers across 10 countries. Eligibility for this trial included being treatment naive, 18 years of age or older, having an HIV RNA of at least 500 copies, and an HBV DNA of at least 2,000 copies. Participants were randomized in a 1-to-1 fashion to the 2 treatment options with randomization stratified by CD4 count, hepatitis B e-antigen status, and hepatitis B DNA level. In total, 243 persons initiated treatment. Median age was 32, and greater than 90% were men, and greater than 80% were Asian. At week 48, there was a suggestion of better HBV virologic outcomes in the BEe-HIVe FTC arm, with 63% of individuals in this arm achieving an hepatitis B DNA level of less than 29 versus 43% in the TDF-FTC dolutegravir arm. Hepatitis B surface antigen seroconversion was also higher at week 48 in the BEe-HIVe FTC arm at 8% versus 3% in the TDF-FTC dolutegravir arm. However, by week 96, hepatitis B virologic outcomes were largely similar across groups, with 75% of those in the BEe-HIVe FTC arm having a HBV DNA less than 29 versus 70% in the TDF-FTC dolutegravir arm. And hepatitis B surface antigen seroconversion occurred in 9% of those in the BEe-HIVe FTC arm versus 7% of those in the TDF-FTC dolutegravir arm by week 96. As previously mentioned, hepatitis B resistance to lamivudine is common, which is why lamivudine monotherapy is not a recommended antiviral strategy for co-infected or monoinfected patients. Furthermore, lamivudine resistance can lead to partial entecavir resistance, so entecavir should be avoided or given at a higher dose of 1 mg daily in lamivudine-experienced individuals. Thankfully, tenofovir resistance is very rare in hepatitis B, although testing for this is available. It should be noted that declines in hepatitis B DNA can be much slower than in HIV, and hepatitis B DNA levels may be detected for several years after starting appropriate antiviral therapy, even in the absence of any resistance. Improved virologic response has been seen with the addition of entecavir to TDF, but it's not clear if this is necessary in most cases. Stopping hepatitis B active ART should be avoided in patients with co-infection. In a retrospective analysis which included 109 individuals from the Swiss HIV cohort study, LFT elevation occurred in 29% of co-infected individuals who were taken off of lamivudine, and 3 of these patients presented with fulminant hepatitis with 1 death. If for some reason HBV therapy must be discontinued, the Opportunistic Infections Guidelines recommends monitoring transaminase levels every 6 weeks for 3 months, and then every 3 to 6 months thereafter. In the setting of co-infection, hepatitis B-IRIS or immune reconstitution inflammatory syndrome is not common, but the risk is highest among those initiated on non-HBV active ART and typically occurs within the first 12 weeks of therapy. Hepatitis B-IRIS can be challenging to distinguish between drug-induced liver injury or other causes of hepatitis and IRIS. In patients at risk for hepatitis B-IRIS, clinicians can consider checking LFTs every 6 to 12 weeks after introduction of antiretroviral therapy, and then every 3 to 6 months thereafter. In the case of HBV-IRIS, recommendations are to continue HBV active ART, and there is insufficient data for or against the use of steroids. Hepatitis D virus, or HDV, is a unique hepatitis virus that requires hepatitis B surface antigen for replication and therefore only affects individuals with chronic hepatitis B infection. Co-infection with HDV leads to faster progression of fibrosis and increases the risk for hepatocellular carcinoma. The estimated prevalence of HDV among hepatitis B surface antigen positive individuals is 4.5%. with risk being higher among people who inject drugs and persons with hepatitis C or HIV co-infection. European and Asian guidelines, as well as many experts, recommend screening all patients with chronic hepatitis B for HDV. However, the AASLD guidance recommends taking a risk-based approach, screening individuals from endemic areas, people who inject drugs, men who have sex with men, people with multiple sexual partners, persons with HIV or hepatitis C co-infection, and those with elevated LFTs in the setting of a low hepatitis B DNA level. Finally, screening for hepatocellular carcinoma, or HCC, is an important consideration in persons with chronic hepatitis B, as hepatitis B can lead to HCC even in the absence of cirrhosis. Persons with HIV and hepatitis B co-infection are at risk for developing HCC at an earlier age when compared to hepatitis B monoinfected individuals. And many experts recommend screening all persons with HIV and hepatitis B co-infection starting at age 40. To screen for HCC, it is recommended to obtain both a hepatic ultrasound and a serum AFP every 6 months. For persons with hepatitis B monoinfection, HCC screening is recommended in all those with cirrhosis, in men from an endemic area starting at age 40, in women from an endemic area starting at age 50, in persons from Africa at an earlier age, as early as the 3rd decade of life, in persons with a first-degree family member with a history of HCC, and in persons with a Page B score greater than 10, which is calculated based on several patient factors. To learn more about hepatitis B, please check out the Hepatitis B online curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis B online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.